Hi, I have 8 practice test questions for you on the psychiatric aspects of grief at end of life. Ready? Let's learn psych fast. Question 1. What theoretical framework is commonly used in grief counseling for individuals facing imminent death? A. Psychoanalytic theory. B. CBT. C. Kubler-Ross model. Or D. Humanistic essential perspective. The answer is C, Kubler-Ross model. All right, so when we're delving into the realm of grief counseling for individuals nearing the end of their journey, the Kubler-Ross model takes the spotlight. Elizabeth Kubler-Ross proposed this model, often known as the 5 stages of grief: denial, anger, bargaining, depression, and acceptance. It's like a roadmap, helping both clinicians and patients navigate the emotional landscape that often accompanies the awareness of imminent death. So if C was the correct answer, why were the other ones incorrect? Well, option A was wrong because while psychoanalytic theory has its place, especially in understanding unconscious processes, it doesn't provide the structural framework that the Kubler-Ross model offers for addressing specific stages of grief. B is incorrect because, CPT is a powerhouse in many psychological interventions, but it doesn't capture the sequential unfolding of emotions in the face of impending death as systematically as the Kubler-Ross model does. So, and D, that's incorrect too. Humanistic existential perspectives emphasize personal growth and meaning making. They may lack the specific stages that the Kubler-Ross model delineates, making it less applicable for the structural approach needed in the imminent death scenarios. So in the journey of grief counseling for those facing the end of life, the Kubler-Ross model serves as a guiding companion, helping both clinicians and patients navigate the complex emotional terrain. Question 2. An advance directive is a document that does which of the following? A. Addresses decisions regarding end-of-life care only. B. Allows patients to have their wishes honored only in the state in which they live. Or C. Becomes effective prior to incapacity in most states. Or D. Communicates preferences regarding the end-of-life care before incapacitation occurs. Answer D. This is the definition of advanced care directives. Choice A, an advanced directive addresses decisions regarding end-of-life care as well as any aspect of care. Choice B, that's not the option. Advanced care allows patients to have their wishes honored in every state in the U.S., not just the state in which the patient lives. And choice C, that's not correct either. In most states, an advanced directive does not become effective until incapacity to make healthcare decision occurs. Question 3. Live-in wills completed long before a person experiences a life-limiting disorder are usually not helpful because of which of the following reasons? A. Many people change their preferences as circumstances change. B. Preferences made early in life are usually detailed, which can be confusing to practitioners. C. Preferences made early in life can be unethical and medically unwarranted. Or is it D? They usually do not provide information about a person's core values with regards to goals of care. The answer is A. Many people change their preferences as circumstances changes. This is one of the disadvantages of creating a live-in will earlier in life before life-limiting disorder occurs. With choice B, that's wrong. Regardless of when they are completed, detailed preferences stated in live-in will are helpful because they provide more guidance for practitioners. Choice C, that's incorrect. Regardless of when a live-in will is completed, this document cannot compel a healthcare practitioner to perform unethical or medically unwarranted procedures. Choice D, yep, wrong as well. Live-in wills provide information about core values regarding personal priorities of goals of care, which can be much more helpful in guiding care than specific treatment wishes. Question 4. In a durable power of attorney for healthcare, one person, the principal, names another person to make decisions about only healthcare. Which of the following is the strongest virtue of a durable power of attorney? Is it A, enables a designated decision maker to make immediate decisions for the principal, even if the principal has the capacity to make decisions? B, enables the designated decision maker to respond to here and now circumstances? C, provides binding instructions for the designated decision maker about the principal's end-of-life decisions? Or is the answer D, provides the designated decision maker with limited information about medical facts and patient prognosis? The answer is B, enables a designated decision maker to respond to here and now circumstances. The value of a durable power of attorney is that it enables designated decision maker to make real-time decisions about the principal's health care. Choice A is incorrect. In some states, a durable power of attorney is immediately effective, even if the principal has the capacity to make decisions. But as a practical matter of principal who retains the capacity to make decisions can direct or override those decisions. Choice C, wrong as well. Why? Well, because the durable POA does not bind a decision maker to make any decisions. It simply guides the decision maker. Choice D is wrong because the durable POA, the decision maker is allowed to know all the medical facts and information about prognosis in order to make an informed decision once the principal becomes incapacitated. Question 5. If a patient is potentially dying, the patient should be involved as possible with healthcare decision making. However, if a patient lacks the ability to make healthcare decisions and has no authorized surrogate, it is most appropriate to consult the patient's spouse or domestic partner first. If the patient does not have a spouse or domestic partner, which of the following individual is most appropriate to consult next? Is it A, the adult child, B, closest friend, C, parent, or D, sibling? The answer is A, the adult child. If a dying patient does not have an authorized surrogate to make healthcare decisions and has no spouse, then the adult child is consulted next. Choice C is the next person to consult, then choice D is next, and finally choice B would be consulted. However, the exact scope of authority and the priority of permissible surrogates vary by jurisdiction. Question 6. Which of the following best differentiates hospice care from palliative care? A, is incompatible with curative treatments. B, provides psychosocial counseling. C, provides spiritual guidance and meaningfulness. Or is it D, relieves bothersome physical symptoms? The answer is A, is incompatible with curative treatments. So hospice care providers provide comfort and meaningfulness. It does not provide a cure. Palliative care can provide to patients for whom a cure is possible. For example, a patient who has liver failure, they can receive palliative care while waiting for a liver transplant. Choice B, C, and D are provided by both palliative care and hospice care. Question 7. Many healthcare practitioners worry that treatments such as opioids for pain may hasten the death of a dying patient, but this is uncommon. Skilled medical care with drug titration and appropriate dosages are used so that the resultant death is not considered hastened. However, in some states, the demise of a dying patient can be hastened via an assisted SI. In which of the following states is assisted SI currently legal? A, Nevada, B, New York, C, Utah, or D, Vermont? The answer is D, Vermont. Assisting with SI is authorized under specific conditions in Vermont. It is also authorized under specific conditions in California, Colorado, DC, Hawaii, Maine, Montana, New Jersey, Oregon, and Washington. The other choices are just incorrect. All right. Let's see. Last question. Question 8. A 62-year-old man is brought to the doctors by his daughter. 4 weeks ago, his wife died from metastatic breast cancer. He reports being tearful every day, but his daughter is concerned because he is constantly picking fights with her over minor matters and issues relating to the family's past. The daughter also reports that he has on occasion described hearing his wife talking to him, and on one occasion he prepared a meal for her. Despite this, he started going walking again with his friends and saying that he's determined to get back on track. What is the most likely diagnosis? A. Atypical grief reaction. B. Depression without psychotic features. C. Delusional disorder. D. Depression with psychotic features. E. Normal grief reaction. Answer? E. Normal grief reaction. Hey, we all know that feeling sad and grieving after losing someone close is totally normal, right? It's part of being a human. But here's the thing. Understanding the stages someone might go through during grief can help us figure out if it's the usual kind of sadness or if there's something more going on. You've probably heard of the classic stages, denial, anger, bargaining, depression, and acceptance. Dagda. Now, not everyone follows this exact script. It's more like a toolkit for understanding. Oh, and keep in mind, abnormal grief reactions, the ones that don't quite fit the usual pattern, they tend to show up more in women. And if the death hits out of nowhere, that can throw a curveball too. If the relationship before the death was tricky, or if the person doesn't have a strong support system, that can make the grief journey a bit tougher. So it's like having a heads up on what might be a rocky road and being aware that everyone's grief journey is a bit different. All right, all done. Hey, try this next video. I think this one might help you.